session, and if the rest of our panelists could please, if you don't mind, turning on your camera. We've got a couple of questions, and then we can take additional questions from our audience here. So this is just wonderful talks, and really appreciate it. We've got two questions to start with. I think I guess they'd primarily be for Dr. Cohen, although definitely welcome input from our other panelists. First, with regard to the tie between EBV and MS, had there been any trials, or are there any planned trials of antiviral agents for MS?
Yeah, so I'm aware of two trials of valacyclovir for MS, neither of which showed a statistical improvement in MS with those trials. We tend to think of most of the EBV-associated diseases due to proliferation of latently infected cells as opposed to active viral replication. Valacyclovir will prevent active viral replication, but these latently infected B cells, when they divide and make more EBV, they don't use the viral DNA polymerase. They use the host DNA polymerase, which is not sensitive to valacyclovir, acyclovir, ganciclovir. So it may not be that surprising. The other comment I'd make is that when people have looked at viral loads in people with MS, the level of EBV in the blood is in most studies is not increased. Again, suggestive that there may not be active production of EBV virions, more so in MS versus other diseases.
Thank you. There's one other follow-on question about, so has the balance between MS patient T-cell responses against lytic antigens versus latent antigens been described? And in the MS patients potentially might lose T-cell mediated inhibition or control of underlying EBV replication in infected memory B cells.
Yeah, so I mentioned a study where they saw increased T-cell proliferation in EBNA1, one of the latency proteins. I didn't have time to say it, but in that same study, they looked at T-cell proliferation in response to some of the lytic EBV proteins and did not really see an increase in patients with MS. So it seemed to be more for the EBNA1 protein, suggesting again that the latency T-cell responses may be more important than the lytic T-cell responses.
And I just not to skew things too much, but I do have one other follow-up question was, so it is very interesting. Just the time elapsed between EBV and onset of MS is really fascinating, and so I wonder whether or not that. I'm curious about your thoughts, Dr. Cohen, about whether that could be evolution of viral factors versus immune cell evolution. I'm curious if there's any thoughts you could share on that.
It would just be pure speculation, to be honest. I don't think we really know. I am intrigued by that as well, and there's also an association with EBV mononucleosis and EBV Hodgkin's lymphoma, and that time period between EBV infection and Hodgkin's lymphoma has a median around 5 years. And I tend to think there's something in the immune system that is, that's involved in it more than the virus per se, but I honestly don't know. But it's curious that latency period is similar for both of those diseases. And again, maybe some of the other panelists, maybe Bibi may have some comments.
So I think that the fact that they have seen increase in neurofilament before MS really suggests that, the CNS inflammation and tissue injury happened before clinical MS was diagnosed. And we see that basically subclinical disease is enormously common in multiple sclerosis, right? Even when we diagnose people with progressive MS in their 50s, I look at their MRI and it's obvious that they had the disease for, 3 decades. They didn't know about it. They were asymptomatic. In fact, the amount of asymptomatic MS on autopsy studies is about 0.1%, which is about the same frequency as symptomatic MS. So, many people are not aware of the fact that they have this disease.
Thank you so much. We have another question, since we have several institutions here represented, and so this is from Dr. DiBiase. Our model for the MIS-C task force incorporated immediate notification of our entire multidisciplinary team to allow rapid and integrated treatment decisions and crosstalk between subspecialists that would seem to lend itself well to neuroimmunologic disease. So she asked, has this model been implemented at other centers? And perhaps if Dr. Maskal and Dr. Velikova, if you could you speak to us about the kind of the models for response and task force at your institutions for dealing with neuroinflammatory diseases?
Yeah, I think some days we do better than others. I think often the intensive care unit is the glue. I think where the rheumatologist and myself often get involved is in the ICU setting. I think the ICU setting is actually a lot less siloed than hospital floors. We have different services involved, whereas in the ICU, I think they are often the gatekeepers. And at least in our institution, we have a neurocritical care floor or pod in our ICU. So I think it easily allows people to do multidisciplinary rounding. Some of the challenges with American cutting edge neurology is that obviously people are subspecialized. So you have epileptologists and you have neuroimmunologists. And sometimes that becomes a challenge in terms of different skill sets if the pathophysiology is not just inflammation or seizures secondary to inflammation in terms of the various hands. But I agree with the question that got asked. I think we have learned a lot from MISC as rheumatologists during the various waves of MISC here in my institution. We had twice a week huddles of all the stakeholders where patients could be discussed. So not just in real time, but after the fact and back and forth, and allow sign out to the teams. I think we haven't quite as been successful in terms of neuroinflammation, but I think that's sort of potentially the model in terms of ensuring that all the stakeholders are aware of the child from the get-go and not sort of after the fact. So I agree. And that, at least that's where we're aspiring to.
So I would like to add that I completely agree with Dr. Maskal that what we are lacking is point of care diagnostics, right? The clinical laboratory, even the white blood cell count is done on undiluted, unconcentrated CSF, which means that, that's very misleading count because you can't find kind of moderate level of pleocytosis in those instances, right? So we have today already really fantastic biomarkers that are incredibly sensitive for inflammation. For example, soluble CD27 is a fantastic biomarker with 90% sensitivity for intrathecal inflammation, but we don't have commercial assays. And, a laboratory like mine can't afford to run this on a weekly basis, right? So we are running these things, once every 3 months when we accumulate enough patients to have a plate. I think the model that Mayo Clinic is doing, that basically they integrate their research laboratory. So the advances from research laboratories are tested in their clinical laboratory, which is then validated as an assay and then it's commercialized. I think that is absolutely the model, entrepreneurial model that should be implemented. We can't implement it at NIH. NIH is not entrepreneurial. I did talk to laboratory people and they said, no way, right? So yeah, I think that this is huge problem. And of course, for us, we mostly see outpatients. So, but I totally understand that my collaboration with, Beth Wells and seeing her patients, right? Yes, you need this information really fast, and we can't provide that information fast enough.
And I would piggyback on that as you think, again, drawing on the MISC and COVID story, our huddles would have lab medicine involved in them because they were sort of the stewards of point of care antibody testing to confirm COVID. Obviously, PCRs will conferred response that, pre-antibody response to COVID as part of MISC. And any sort of issues with the lab or systems-based approaches were sort of discussed at those huddles. I think that piece is missing, and even commercially available assays will take 3 to 5 days to come back often, or even longer as we think about some of the HLH type of biomarkers. And even those are sort of lacking. You're sort of making decisions in the dark that are really based on phenotypic issues or an imaging, and you might be missing the mark. And I do think as a rheumatologist, time is neuron, right? So I am a stranger in a strange land here, but the brain is not as forgiven as the joints in terms of damage and inflammation. And for some of these disorders, there probably is a very short window of damping inflammation before you lose control. So that the point of care diagnostics are, I wish I was an entrepreneur. I wish I was a lab person. I'm not. I'm a clinician. But that piece really, I think it's where we're going to go, and it really is lacking.
Yeah, and Dr. Maskell, I would even say, even for monitoring of treatment response, right? You mentioned cyclophosphamide. There was this notion in MS field that cyclophosphamide is small molecule, it penetrates, it doesn't. So once we got CSFs from Beth Wells, from her patients with paraneoplastic encephalitis, right? We saw that it doesn't. It works in periphery. It doesn't work in CNS. I mean, it's really very difficult to inhibit inflammation in CNS. What we have is methylprednisolone. That works. That really works. Now, unfortunately, it works for a short time period as long as you are giving it. But basically, none of these other, once the inflammation is compartmentalized into CNS tissue, none of these things work. They work by 10%. We gave rituximab intrathecally. It works by 10%. It doesn't in periphery. Right? Because even for some of these depleting antibodies to actually work, you need to have a complement. You don't have that much complement in the CNS tissue. You need to saturate the receptor. You don't saturate the receptor, even if you give it intrathecally, because you can't get enough dose to saturate the receptor. You don't have CD56 dim NK cells. You have CD56 bright NK cells. So even the ADCC that you need to kill the cells is not there. Right? So there are many things that we are taking for granted, but when we actually start studying them using CSF, we realize that that is not true.
Thank you all very much. That was actually, I was going to ask you, what are the greatest needs you see? And I think we pretty much hit the nail on the head. I did have one other quick question, and so it's, I guess, primarily probably for Dr. Belikova, but I welcome the other panelists' thoughts. So you showed some really amazing data on machine learning in MS. I'm curious if there's either any ongoing studies or your thoughts on machine learning in other neuroinflammatory conditions, particularly with the thought to whether we could make diagnosis faster, given the flood of information that we have, with a lot of our cytokine panels and whatnot.
So for machine learning, you actually need numbers, right? So I mean that's the problem. Fortunately, I had this vision, and I started collecting the CSF samples 20 years ago, right? But you really need 1,000 CSF samples to be able to compile data into reproducible and comprehensive models. So, that's going to be very difficult to establish without, these large collaborative consortia. I think people don't appreciate, even getting like Beth's protocol through the IRB channels of the Children's Hospital has been quite difficult, because I think people don't appreciate the fact that we are still at learning stages, that we need to, the patients need to teach us about their disease, right? That we are at the stage that we must collect this information before we can translate it into reproducible knowledge.
I would add to that the other unmet need or gap as a former fellowship program director is that we need to train more cross-pollinating clinicians and scientists. So, most immunologists are not comfortable in truly thinking about or understanding neuroimmunology, right? And I think many neuroscientists are not comfortable with the immune system. And then rheumatologists are innocent bystanders that have really a fund of knowledge of CNS disorders such as lupus, with little understanding of what happens behind the brain outside of a sort of systemic autoimmune process. Though we're getting better, because periodic, as Dr. Kastner and others are understanding the innate immune system, it's obvious that there's more and more that a rheumatologist can bring to the table. But I think many of our trainees are still siloed. And I know that thankfully the two institutions that put this talk together, I think are trying to change that you have immunologists that think about the brain and vice versa, because I think otherwise we're not going to make a lot of headway.
And I would say the third thing is our outcomes, right? So here at NIH, I have a luxury to spend an hour in examining patient, right? We have a luxury of collecting these functional scales and putting it into this combi-wise granular scale. I'm 100% convinced that without such granular outcomes, we wouldn't be able to validate anything or establish anything, right? Because we can't measure with these really insensitive outcomes. We can't measure progression in 4 or 5 years. And, there is a patient attrition in 10 years. We just don't have the time, right? So that's another issue.